Afternoon, people. Want to call to order the February 2nd meeting of the Oregon Educators Benefit Board by team meeting. Hopefully people have had a chance to look at the meetings, our minutes from the last meeting. Any comments? Okay, motion to approve.
Move to approve.
Second.
Okay.
Okay. And anybody opposed? Otherwise, we'll just go with consensus. Nobody opposed. Reed, you're on. What's that rule called?
The consent agenda, or no, that's not what it's called, but it's by consent, right? Without objection, and then you just move on.
Perfect.
Without objection.
Yeah, so it takes a village here. Okay. First thing up on our agenda is COVID-19 update from carriers and the health authority. Jennifer, I think you're listed first from Kaiser.
Okay, well, thank you for joining us. I have with me Dr. Keith Bachman and Sapari Sturdivant, so they'll join in. I'll get us started. I just wanted to give a brief update. So as everyone I think knows, Kaiser Permanente is an approved vaccine distributor. So we are working to administer vaccines to the community, both members and non-members in our Southwest Washington area, as well as Portland Metro, the Salem Mid-Valley, and Lane County. There are multiple approaches that we are taking right now to make sure we administer as much vaccine as possible in the most safe and effective way. And some of that work has been happening for Oregon residents in the Oregon Convention Center through a partnership with Kaiser Permanente, Providence, OHSU, and Legacy, where we've joined together to create a mass vaccination clinic for Multnomah County, Washington County, Clackamas County, and Columbia County residents. That is allowing us to increase throughput, to merge our resources, and to get as many people vaccinated as possible while kind of blunting some of the supply chain and staffing issues by merging resources. This has been key for educators in the metro area. We have worked with a group of education leaders as well as public health to vaccinate according to the phased approach first set by OHA and then set by the school leaders as to how they wanted to phase the school district child care and early education workers. So that has been up and running. We've completed our first full week of all 4 systems in the Oregon Convention Center last week, and things are getting smoother and smoother as we go. For those that aren't being vaccinated through the Oregon Convention Center, we are vaccinating in Washington out of our Longview and Vancouver offices as supply allows, although supply has been much more limited in Washington, as well in Mid-Valley out of our Salem office and in Eugene out of our Eugene office. Dr. Bachman, would you like to say anything? I know Dr. Bachman was vaccinating. I've been volunteering there too, so some insight about how it's going at the Oregon Convention Center?
Yeah, I had the opportunity to volunteer on Sunday evening, and I got to vaccinate several educators who were all grateful and pleasant and had the usual questions and anxiety about getting a COVID vaccination. It seemed like it was a very smooth process, both as a vaccinator with a high volume, but in a comfortable environment and a safe environment as well, with lots of staff, lots of supervision, people to answer questions, and efficient registration process. So it really was a good experience for me as a vaccinator, and particularly for all the folks, healthcare workers, home care workers, and educators that came through.
Great.
Excellent. Thank you. That kind of points to resources. So each organization is putting in resources to run this, also including retired KP physicians and nurses that are willing to come back. We've got volunteers, National Guard support. It really goes on because all of this has been, of course, stood up in addition to COVID testing, COVID treatment, and the other care that really a lot of these same people are providing. Okay, any questions before I turn it to Sapari?
That's Bill. I'll just say thanks for the webinar you held on with your infectious disease doctor. That was quite informative. I would really appreciated that.
Excellent, thank you. And I think Sapari has one working. We have another one
Yeah,
coming
I
up
would just
for
say,
anyone interested. Sorry.
normalize it. This is really complicated, this vaccination. The rate of information coming out, we're learning about the complications and what to expect from vaccinations, the new virology coming out with the different strains and how each of the vaccines is affected by that. So it is just a complicated time. And it's, I don't expect anybody to have the answers, because I certainly don't. And I'm tracking this as closely as I can. So it's a work in progress for sure. And it is a little bit exhausting tracking all this.
Keith, this is Bob. I have interest in understanding how we're doing with COVID treatment, particularly with monoclonal antibody utilization, where recent studies that I've read show a significant decrease in people who get hospitalized and die when they're treated early. I don't expect you to give an answer today, but I'd love to hear how both Kaiser Permanente and MODA are doing in regards to the utilization of what I think is an underused treatment. Maybe next month.
Great. We'll get back to you on that.
Thank you. And Erica, same in your direction. If you could have your pharmacy people look at how much of the monoclonal antibody infusions are happening through your health plan, particularly if you can do it in regards to OEBB, but just in general would be okay too.
Yeah, one positive note though is the decreasing hospital utilization and ICU utilization in the state and also in our populations as well. So that's been great to see that.
Agreed.
Okay, thank you. Erica and Dr. Singh from MODA, please.
Thanks for having us. We are going to start with Dr. Singh, starting off with our COVID update. Dr. Singh?
Good afternoon, Robin Singh, MODA Health. Delighted to provide a broad update on COVID-19. Globally, coronavirus cases reached a daily and cumulative peak in January, and we now have around 102 million confirmed cases. Although many countries are now showing declines, cases are still rising in other countries. Deaths also continue to rise globally and have reached around 2.2 million. The highest numbers of cases and deaths are in the Americas, as classified and reported by the WHO. Many South American countries are still seeing rises, such as Brazil. Here in the US, we have around 26 million confirmed cases and around 440,000 deaths. This means that significantly more than 0.1% of Americans have died from COVID-19. Furthermore, between 5 to 6% have tested positive, and the true prevalence is several-fold higher than that. Over the last couple of months, Oregon reached its peak of cases and deaths and is beginning to show a decline in both. Most counties still remain at the extreme risk level. For our OEBB members, the year-to-date data is as follows. Active test member count, 20,619. The active test count in total is 27,321. Antibody test member count, 1,470. The antibody test total count, 1,508. The case count total is 1,268. There were 40 hospitalizations with 14 ICU cases, of which there were 4 deaths in the hospital setting. These numbers are based upon coding and mapping of codes, and maybe less than the actual true numbers. The total paid amount for COVID testing was around $2.84 million. The total paid amount for COVID treatment was around $2.35 million. Regarding vaccinations, Oregon has distributed around 665,000 doses, of which around 440,000 doses have been administered. So about 2/3 of them, giving approximately 350,000 Oregonians some level of vaccine protection, either first or both doses. Nationally, around 50 million doses have been distributed, and around 10% are partially or fully vaccinated. Therefore, Oregon is performing at a similar level to other states in terms of vaccinations. Both vaccines, Pfizer and Moderna, with emergency use authorization, continue to show strong safety and efficacy data. Although there are concerns about effectiveness against the growing number of new variant strains that are occurring around the world and are being seen in many states, those strains are still small in numbers. At present, there appears to be protection against most of these strains, even though the efficacy may not be as high as for the most common strain. Whether mutations become sufficient to evade current vaccines completely is yet to be seen. The goal is to ramp up vaccine administration fast enough to save lives and essentially eliminate the virus before it mutates further. Last, Johnson & Johnson's single-dose phase 3 vaccine trial data arrived in the last few days, showing efficacy of 66% up to 85%, depending upon the severity of COVID-19 in the patient subset. It is likely to be approved shortly by the FDA. Supply will likely be limited, however, for the first couple of months, and it would go through the same distribution channels as existing options, though it's still a welcome addition, especially given the single dosing that's currently being proposed. Thank you.
Great, thanks, Dr. Singh. And I just want to provide more of a reminder on the benefits around COVID. We continue to offer no member cost share for testing or treatment related to COVID, and also the vaccines, as both Dr. Singh and Kaiser were discussing. People are getting their vaccines, and we know that school employees are now eligible to receive their vaccines, and vaccines are covered in full as well. So no member cost share for vaccines. Also, we recently sent out a communication to all of our OEB members that we have on the vaccine safety. And so this included a letter and also a flyer that had some really great visuals just to try and communicate the safety of the vaccine. We also have this posted on our OEB specific COVID site, as well as all of the benefit information and other links and information about COVID. So OEB members, if they have any questions on what their benefits cover or the latest news on COVID, they can go to our OEB specific site on that. Any questions for us? Right. Well, thank you very much.
Excuse me. I think we also have someone from the Oregon Health Authority with us today.
Yes, hello. My name's Kati Mosley. I work for OHA. I'm the Director of Health and Education. I think your previous speakers gave a pretty good overview of what's happening in the metro area for educator vaccinations. There is a different and more coordinated tri-county model going on. Around the rest of the state, infrastructure looks similar, but it's more of an LPHA health system and education partner planning piece that's moving that forward, and most areas aren't taking a tri-county approach. I have a little bit of updated information from this morning that might be interesting for you all to hear about. Just in terms of the metro area, they've been moving forward with prioritized waves of educators who become eligible for the vaccine, and districts are communicating that out, districts, private schools, and other, education actors. And they're coupling that with a kind of a staged release of appointment availability on the health system side. So between January 27th and February 2nd, all of the appointments that were released were filled, and there's clear knowledge that at least 800 teachers also scheduled in non-educator slots for the first 2 days of that week, because there was some overlap in the beginning of the educator eligibility and some appointments that were available for other priority populations. Between February 3rd and February 9th, Wednesday through Monday of that week, every appointment slot was filled, and Tuesday the 9th was filled at 72%. And then we're well on track for the coming week, February 10th to 16th, to look at those slots filling up as well. There's still availability there. Districts are going to be communicating out to the next wave on Thursday, coupled with, the health systems releasing those appointments for appointment availability. So that model seems to be going really well. I had hoped to be able to bring to you also a little bit more of a snapshot of what's going on in the rest of the state. And unfortunately, the timing for that didn't line up for this meeting. I will have that tomorrow, but not in time for you all today. Next steps. I'm happy and lucky. I feel lucky to be in a position where I maintain strong partnerships with Oregon Department of Education and the Early Learning Division. And that's really helpful in terms of them being able to funnel concerns and issues that come up statewide around educator and childcare workers' access to immunizations. And we can have those addressed and fixed quickly. I think it's an important partnership in terms of fine-tuning the system across all of these local public health authorities and health systems that are implementing to make sure that the people with the arms from the education side are putting those arms in front of the people with the needles for a poke to take place. So I apologize that I don't have a specific update on the rest of the state. If there's anything else I can share, if there's questions, I would be happy to try to field those or take them back to be answered later.
I have a question. Not quite sure how to phrase it, but the efficacy of the Johnson & Johnson doesn't seem to be up to the 2 that are already in place. Is the state able to choose which ones they're offering, or how is that going to be presented to the citizens? Can you speak a little bit more about this third vaccine?
I can't. Perhaps someone else on the phone can, or the computer. I'm happy to take that question back, though, and see if I can get you an answer.
Jeff, it looks like JJ has a question.
There's the hand. Go for it.
Some of the local public health authorities in Southern Oregon have voiced some concern that as they go through the initial groups that are getting vaccinated, there are some counties that are lagging. Just the nature of their regions is hard to get through that group. And they've been told that they will not get subsequent distributions until all of the counties get through the initial groups. Is that concern valid? And if so, I'm just a little concerned that one county is through Group 1A and subsequent, and they have the ability to progress to the next level. What can we do to help facilitate that?
So thank you for that question. That's not my understanding of how the allocation process works. And if you want to dive more deeply into allocations and the methodology used for that, I'd be happy to connect you with the right folks in OHA who can help explain that.
Okay, Sue.
Jeff, to your question, in my reading, I was hopeful that Dr. Singh and Kaiser were still on the line. My understanding is relative to your question around Johnson & Johnson is that it is less effective in terms of total asymptomatic experience once you have been exposed to the virus, but is highly effective relative to reducing the need for hospitalization. So where the first two, Pfizer and Moderna, yeah, I know, Moderna are 95% effective at both, not only reducing the need for hospitalization, but also the individual not experiencing symptoms. Johnson & Johnson, because it's one, is very effective at reducing the need for hospitalization and ICU care. Versus you may feel cruddy for a couple of days with the experiencing a bit of the virus. But I would prefer that a trained, licensed individual confirms what I just said.
Yeah, Sue, we agree with that. We just reviewed this with our infectious disease expert who basically said what you said in a few more words than that. In terms of preventing hospitalization, severe disease, ICU care, and death, the J&J vaccine is highly effective with really very few cases in people who are vaccinated. Having the one vaccine is logistically better. It's also a vaccine that doesn't need the refrigeration that the Pfizer needs. So I think the pitch from the infectious disease experts and probably from public health will be to be thumbs up on the Johnson & Johnson vaccine when it's available, with the real goal is avoiding severe disease that lands people in the hospital or in the ICU or dying.
And I appreciate that, because I think from a perspective of how we communicate to our members and thinking about communication that's going out relative to efficacy of vaccine, this is a point that needs to be driven home. Quite frankly, when I listened to and then did some reading relative to Johnson & Johnson, I'd be happy to get any of those and be perfectly fine with Johnson & Johnson, because the real goal is to prevent, advanced disease. And the need for hospitalization and or worse. So, but I do think that that's really, really important. The second question I guess I would have along with that, Jeff, is how we are reaching our staff and members who are part of our, disproportionately impacted communities. One of the battles that I'm facing in my own district is the fact that we have offered individuals the opportunity to opt out if they so choose. And for, if they just can't get their head wrapped around it, but really encourage them not to. And the challenge has always been there is a high level of distrust, particularly in our Latinx communities and our Pac Islander communities versus my Black and Indigenous.
So question for the state is that when people are being vaccinated, are they being told which one they're getting?
Yeah, you get a vaccine card that has all the information for which vaccine you're getting on it. And if I could respond as well to a couple of the previous comments, we are working with Department of Education right now on putting together some kind of learning opportunity for educators who might be hesitant to get the vaccine. And in addition to that, in our work with ELD, we are stepping up our Spanish language communications quite a bit, and I think that those will be supportive to those populations as well, and to some of the groups that you mentioned who are particularly vaccine hesitant. So I really appreciate your talking about that, and know that these things are on our minds as well as we are moving through the educator group, wanting to make sure that group has as complete and full opportunity to get informed and get the vaccine as they wish to have.
Great, thank you. Bob Stewart, you have your hand up?
Yes, I did. I was just unmuting myself. Just a couple things. I've been really involved with this from the outset. It's been a remarkable effort. And it was only 20 days ago that we held the first meeting with the chief operating officers from the 4 hospitals in the metro area to try to stand up the whole process of how we're going to effectively, efficiently, and fairly vaccinate our education population. JJ, to your question about fairness of distribution, at the end of last week, there were still 64,000 1A people in the metro area that had not received their vaccination. And the reports from other parts of the state is that not only are they through the 1As, but they vaccinated all the teachers too, all the educators. And so the metro area sees a little different equity issue around distribution, that there are more people in the 1A classification in a proportional way than in other parts of the state. To the Kaiser folks that are on this call, your people have been amazing. We're working directly with Wendy Watson and the COOs from Providence, Legacy, and OHSU. They meet with a small group of educators twice a week to problem solve, and they've been just remarkably good at hearing our concerns and us hearing their concerns, and working towards a process that's pretty effective, actually.
Great. Any final questions? Okay. Well, thank you all for your presentations, information, and updates. Okay, we'll move along. We have a really packed, dense agenda, so keep this moving. Ali, do you want to introduce our next speaker?
Yes, thank you, Jeff. But before I turn it over to Angie, I just wanted to provide a little bit background. I mentioned in the last board meeting that last fall, the major school district associations that you see up on your screen and labor formed a committee to understand the value of OEB with the goal of being able to communicate that value and determine how they and OEB could work closer together on communications, and also to provide input to OEB staff and the board. So as a result, we've done an initial orientation with the group about OEB and have another plan to review our renewal and decision-making processes in February. As I also mentioned, we really think this group will be extremely helpful to us in delivering value to the districts and the employees. The time that we spent with them so far has been really beneficial. But as a part of that work, the group felt it important to understand the impact of OEB decisions on the districts. And really that's our goal today, is to really think about that and discuss that. As you recall from our consultant's wheel of drivers of healthcare costs, that while OEB is responsible for some of the major drivers, the districts drive key decisions that impact healthcare costs, specifically employee and dependent participation, program offering, and subsidy levels. In addition, the success of our strategies requires the support of the districts for implementation. As such, it is important to understand how our decisions play out in the school districts with the goal of how we can best all work together. So really pleased to hear from Angie Peterman, who's presenting this information today, and we look forward to working this group and supporting our collective goals. Angie.
Thanks, Ollie, and thank you to all of you for the opportunity to share some information today regarding the OEB rate impacts to districts, and we're just going to touch on some of the more significant issues I think that districts address. Rose, are you advancing? I'm not sure who's advancing slides. So.
Angie, if you can get closer to your
Yes,
microphone, that would be helpful.
You're having trouble hearing
just say
me?
next slide.
Okay. Okay, so if we can go to the next slide. I know there's a lot to cover today. I don't want to take a lot of time, but as Ollie mentioned, we want to talk a little bit today about the OEBB rate impact on districts, how that fits in with negotiations, what happens with PERS costs as another significant cost driver for districts as we negotiate and look at the distinction between salary increases and benefit premium increases, and then touch on current service level from the state level, how it works and what it how it impacts districts at this point in conjunction with OEBB. So next slide. I know that the board is very familiar with the rate setting process and establishing the overall rate impact or rate increase, excuse me, through the rate setting process. And I very much appreciate the presentation and the work that Ollie and Damien have done with our work group to help me understand even further how that process works. But so obviously OEBB is establishing plan rates. They calculate an overall rate increase. Districts then face working with their unions to determine the contributions that districts will make toward their premiums, the plans that will be offered to staff in individual districts, if there'll be supplemental coverages like accidental death, long-term disability, short-term disability, life insurance, those kinds of things. And then obviously, ultimately, it rolls up into the district's costs and budget. Next slide, please. So this slide I'm sure you probably have seen, but it was from the presentation that Damien and Ollie did for us, and I thought it was great, so I wanted to incorporate it today just to give you an idea of, on the left you can see plans 1, 2, 3, and 4. You can see the varying rate increases on those individual plans, and then the calculation methodology that's being used to ultimately arrive at an overall 3.37% average increase in OEBB rate plans. And this is significant in that as districts look at the plans they're offering, we're going to talk a little more in future slides about what happens to a district that's maybe selecting only Plan 4, and their rate increase is going to be 9.2% regardless of what's happening in the program as a whole. Next slide. So district considerations, which plan options are going to be available? In many cases, districts make every plan available. In some cases, districts make only a few of the plans available. Sometimes that's directed by geographic issues. If I live in the southern part of the state, for example, in Douglas County, where I'm from originally, my options as far as plans available to me and services within the geographic area that I'm in are limited. So while some districts may have the ability to offer a multitude, other areas may face the reality that they have constraints on the plans that they can offer. So I touched on the previous slide on, the what if. So if I'm in a district in Douglas County that only has maybe plan options 3 and 4 available, I'm looking certainly at a higher overall percentage increase in costs to the plans in my district offered to my employees. And that's not, an issue as a result of OEB setting rates in any particular way. It's a reality of the geographic area and who is or isn't available to serve. But it does have a very significant impact as I look at bargaining and negotiating with my employee groups on the coverage available and what I'm going to pay. So in addition to those types of factors, I'm also guessing which plans will, if I have all plans or a multitude of plans, which plans will my employees select? Of those plans, how many have potentially other coverages, so they won't be covering family members, or how many don't have and they will be covering additional members in the process. And as I'm, contemplating all these moving factors and beginning conversations, certainly with my union representation, then I'm also looking at how am I going to develop a budget relative to plan costs, and how do I estimate rate increases when, fortunately, we get an advisory rate potentially, or know that rates are limited and constrained to some extent by the statutory 3.4%. But obviously, as demonstrated on the previous slide, individual plan rates can fluctuate very dramatically and very differently from that overall average rate. So it becomes even more problematic as we're looking at negotiations and conversations around what we're going to provide in the way of coverage, but what the financial impact of that is going to be. Next slide. What we've found over time, and I've been in this business for 30 plus years, and when I started, health insurance way back in the 80s was much less expensive, and I enjoyed having 100% of my health insurance premium for my entire family covered by my employer. And certainly over time, as circumstances have changed and those costs have gone up so dramatically, like many districts, my district found themselves in a position of having to ask employees to share in that cost. So part of our process, obviously, with negotiations is determining how much contribution the district's going to make. Is it going to be a fixed dollar amount contribution? Will it be a percentage, a premium contribution? Will it be 100% of employee-only coverage, for example, and then some percentage thereafter for additional individuals, dependents covered? Are we going to use a composite or a tiered rate? Do I have a health insurance pool in my district? In some cases, I have a fixed dollar contribution, and in the event that employees select plans where the premium amount for that plan is less than that cap or maximum, then those excess dollars can be placed into a health insurance pool and then further distributed to those individuals that had out of pocket. So in the last 30 years, I've gone from no out of pocket for my health insurance plans to, maybe $400 if I have a family and choose one of the richer benefit, lower deductible types of plans. So what we found in statistically looking at data provided by districts is that about 86% of our districts have a cap. Of those with a cap, 91% are fixed dollar amounts. And we have about 5% that are a percentage of premium. And then about 6% overall that 5%, 6% that have no cap at all. So they're paying 100% of premiums. And I don't know based on which plans and so forth, but that's the information that we were provided through a survey we've done. Contribution rates range from a low of $825 per month to a high of $2,268 per month. The average reported was $1,421 per month. Employees then, of course, bear whatever additional costs there may be out of pocket. So I touched on the health insurance pool, and I wanted to share some information, obviously, about that pool. But before we do, I also wanted to highlight that this is obviously a very dynamic process, and there are lots of competing interests, as you would expect at the table as we're going through this process and having these conversations. So the more plans that we make available to our employees, obviously, the more guessing that there is on the part of district staff in trying to determine who's going to select which plans, whether or not it'll be family coverage, employee only, employee spouse, all those, various aspects of determining cost for premiums and plans. Many districts move toward offering incentives for the high deductible HSA qualifying plans. And those are the plans that we now, as you know, are seeing the higher increases as far as percentage increases in costs from one plan year to the next. So with that in mind, I wanted to share with you just a real simple example of what happens with the district health insurance pool. So in this case, I've got employee only coverage, employee spouse, employee children, employee spouse and children or family. I've got a column showing you what the premium is, the district's contribution in all cases. In this example is $1,200. So the only coverage that has a premium contribution available to go into the pool is employee only, but depending upon how many individuals in the employee only coverage area, there are dollars available. And as you can see, if I'm employee spouse up to employee with children, I'm looking at an out-of-pocket expense that may range from $100 a month to as much as $900 per month. These aren't based on any actuals, just examples from historic information. If you'll go to the next slide, please. So as I said, in this case, in my example, employee only, I have 30 employees with employee only. So the district, in effect, from the amount of contribution that is not going to premiums, there's $15,000 available to then distribute through the pool to other individual employees. So those employees, in this case, I've got 25 employees that are employee and spouse. I have 15 that are covering themselves and children. And then I have 30 that have full family. And as you can see with those numbers, the amount of out-of-pocket cost for those other three groups is $36,000 a month in this example. And while this isn't based, as I said, on anything in particular, as far as actuals, it is, I think, a reasonable representation of what happens in districts. And districts then face the calculation of how are we going to distribute this $15,000 amongst these other groups. Sometimes it'll be just a flat, how many employees do I have that are bearing some out of pocket, and we're going to do a calculation to provide funding based on that. Sometimes it's based on the percentage of premium that each classification has. So those with full family would have a higher percentage than those with employee and children only. And I think that obviously the formula can become very complex and include all sorts of set-asides. And one of the things that is also a reality as districts are negotiating and looking at building their budgets is that staff changes over the course of the year, and the selection that a new staff member may make may be very, very different than the person that they are replacing in their district. So districts also have to be aware that they need to have some sort of small reserve or cushion. Okay, next slide, please. And I know I'm going quickly, but I'm trying to make best use of the time that you guys all have. So hopefully if you have questions, we can get to them. Other negotiations, considerations, districts look at offering professional development, obviously extra duty stipends, whether that's coaching or maybe it's an advisor for a club or activity. Maybe it has to do with music and fine arts. And then obviously another very significant cost driver that we all are very aware of is PERS and our retirement costs. When we look at the interaction between salary, health insurance, and PERS costs, obviously when districts are looking at negotiating with their employee groups, the employee group is striving to see as much money available and in the pockets of their employees as possible. Districts who have a similar interest will also be looking then at, I have limited resources, and how am I going to maximize those resources with the employees that we have? So if you'll go to the next slide, please. Oh, you already did, sorry, thank you. With regard to PERS costs, every dollar that we spend in additional salary costs us an additional 27.2% currently in employer PERS rate for districts that are in the school district's pool. Now, there are a number of districts that have side accounts, and we're not going to get into that entire conversation, but for purposes of this conversation, I've just looked at the school pool and the rate that's in place this current biennium. So for every $100 that we increase compensation in the district, part of our consideration is that our retirement cost is going to go up an additional $27.20. So one of the things that will happen in the district, obviously, is we might look at how we want to contribute more toward health insurance, because that dollar goes to the health insurance premium, reduces the employees out of pocket, but doesn't carry with it an increase in PERS costs or Social Security or Medicare, unemployment, any of those other factors. So I just did a quick example so that you can see if I did an annual salary increase of $600 for an employee, our additional PERS costs is going to be another $163.20. In my example, that means total cost for that increase is $763. I've got 650 employees. That means my budget cost, as I'm looking at putting my projections together, is almost $500,000. If I take that same $600 and I contribute it into health insurance for 650 people, my cost is $390,000. So in this case, we're talking $105,000, $106,000 additional costs in salary. Obviously, the OEB board doesn't have anything to do with those choices and decisions, but we thought it might be important and helpful for you to understand sort of the interaction of salary and PERS and health insurance as we are moving forward. So next slide, please.
So, Angie, can I ask a question real quick? This is Robert Young from OEA. So who is the intended audience for this? Because it feels like a portion of this has gone into bargaining, and so I'm just curious.
Oh, I'm not. So the only intent here was to share with the OEBB board this information about what's going on from the district's perspective and the interaction of these things. Not trying to get into bargaining, not trying to get into positioning one way or another, and I apologize if it seems that I am.
No, if it's a presentation to districts, then I totally understand that, right? I want to know who the intended audience of this presentation is.
Right, and at this point, it was only intended for the OEBB board.
Okay, thanks.
Okay, sure. Okay. As I mentioned, districts estimating costs. Maybe it's a fixed contribution amount per employee with the pool. Maybe it's fixed without a pool. Maybe it's a percentage of premium. My experience, typically districts, as our statistics indicate, have moved toward trying to do a fixed dollar percentage of premium. Can be very difficult because individual plan premiums obviously can fluctuate dramatically from one year to the next. And in some cases, however, we've not done ourselves any favors, and we have agreed to do a fixed dollar amount plus some percentage of premium increase. So in all those cases, obviously, or just the process becomes more complex, and we are sometimes our own worst enemy in this process by trying to be innovative and creative and find ways to stretch dollars. Sometimes we create a situation down the road that's much more difficult for us. So obviously, we all know resources are insufficient to meet our ever-growing and changing needs in K-12 as well as higher education and virtually every, I think, human service area that our state budget helps to fund. Districts spend about 86% of their annual general fund budget on personnel costs. So a very small portion of our budgets go toward non-personnel expenditures like supplies or purchased services for repairs and maintenance perhaps, or equipment for classrooms, technology, those kinds of things. And so if we look at how we go about estimating our costs, obviously one of the simplest and easiest is I have a cap. It's going to be $1,200 per month per employee. I have this many employees that are going to be eligible. I'm going to do that calculation, and that's going to be what my budget's going to be going forward. So if I had 100 employees, obviously, my budget would be $120,000 for those 100 employees for the year. If we were looking at annual amounts, just to keep numbers very, very small. That's not obviously the reality of what we're dealing with and what we're seeing. So districts need, I think, your assistance, if possible, to get more information earlier about what premium rates are doing and what potentially is happening with individual plans as opposed to what we know statutorily, OEBB is limited to in the 3.4% calculation. Some of the other factors that districts are dealing with is we might be looking at that HSA contribution that I mentioned. So if you've chosen the higher deductible HSA eligible program, we may be contributing $50 a month toward that HSA account on your behalf. In some cases, employees have other coverages and have chosen to opt out of our coverage, or they choose only to cover themselves because their spouse, as I mentioned earlier, might be covering children. So many factors, and I know that you as a board face dealing with all those factors as well in trying to evaluate who's going to choose which plan should we offer, what sort of benefits should be available under the plan, and so on. Next slide, please. So our health insurance budgets boil down to sort of looking at trying to determine our contribution toward the health insurance premium, the one component, contributions towards other supplements like our HSA or OEBB, for example, was real popular at one point. Are we going to pay a portion of life insurance premium? Are we going to pay long-term disability? Common in many districts to pay long-term disability on licensed employees, short-term disability on classified employees. Are we looking at modifying the plan offerings that we have or other incentives to try to incentivize our employees to make more informed choices and decisions with regard to their health insurance coverage and utilization of that coverage? So while OEBB has been able to demonstrate a 3.4 or less % increase in recent history before certain taxes and fees, I understand, districts are seeing on average a 5% increase in their actual contribution and cost toward health insurance. For all the reasons that I've already touched on, obviously, it may be related to the plans available geographically, it may be just the makeup of staff and the choices that employees are making, or whether they didn't used to need to cover their family and now their spouse has lost his or her job and now they do need to cover family. So all of those moving pieces and parts obviously create dynamics that we're doing our best to try to anticipate, as you are, but when it comes to calculating our budgets and then looking at the impact that has on current service level, which is where I'd like to go next, the OEBB rates have an impact that I'm not sure if most folks understand. So next slide, please. So current service level, the CSL, there is each biennium a conversation obviously around current service level, what's the cost to continue to maintain the program services that we currently offer in K-12 to our students. It's not intended that current service level take into account necessarily new programs or services, not necessarily reducing class sizes, those kinds of things, but simply if we're going to continue exactly what we're doing today into next year, what will it cost us to do that? So it's a biennial calculation, includes compensation increases that are estimated by both the Legislative Fiscal Office, who's doing, and in conjunction with the Department of Administrative Services, is doing the state estimate of current service levels. Has obviously OEBB rate increases or decreases are come into play, as do retirement increases and decreases. Next slide, please. So I wanted to just give you a quick rundown of comparison so we can talk a little bit about the components in this formula and the impact that they are realistically having on K-12 and setting our budgets and determining current service. So the two columns in this, here are the major components of current service level calculations. And as I said before, 86% of our budget is personnel. Therefore, these are obviously the most significant and important components. So DAS, Legislative Fiscal, has put together a set of criteria and assumptions. Their assumptions being salary increases, for example, will go up 2.16% over the next biennium. Last column, Oregon ASBO, working with a number of districts throughout the state, have historically been developing our own current service level, trying to adhere to the same standards that LFO has set as far as, simply looking at the services we provide today and carrying them forward into tomorrow. Ours is 2.45% salary increase. We have step increases. You can see the difference. Health insurance. Like I said, because of the statutory limitation on the average increase in the premium for OEBB plans, LFO sticks to the 3.4%, which does not necessarily, from our perspective, match what's actually happening when you consider there are fees and other taxes potentially that are outside of that rate. But as I said, OASBO is sticking with a 5%. This particular biennium, one of the more significant differences between our CSL calculations is the PERS rate change. So LFO is looking at a 6% reduction. We don't believe that school districts will see a 6% reduction. We think it's more of a 3.5% reduction. But you combine all these factors together, and at the end of the day, we end up with a blended compensation rate that's utilized in determining what CSL costs will increase for personnel in the first year and the second year of the biennium. In the first year, the blended compensation rate through all this process is 0.03%, basically flat funded from the LFO DAS perspective. OASBO believes we're going to be looking at a more than 2% increase in compensation costs as we go forward into the biennium. So this difference in percentage is equal to about $250 million in the formula, and the equivalent of about 2,000 teaching positions across the state based on our average estimated cost per instructional staff person. So it's obviously quite significant in our review and calculation process. And while the OEB rate differential is not nearly all of that amount, it is a component of the cost differential that we're dealing with, and difficulty that we're having in explaining our differences, obviously, for costs. So next slide, please. Obviously, this is a very complex set of calculations, lots of factors that I've just briefly touched on, just sort of whirlwind through all of this information today. What I would say is that we very much appreciate an opportunity to begin these conversations and having this dialogue. I think the work group that I'm participating in and that Ollie touched on is going to be hugely hugely beneficial to all of us. I'm looking forward to hopefully having Ollie and Damien do some presentations to my membership on the OEBB rate setting process and side of things. But one of the asks that I would have for the board to consider is if there's a way that you could get individual plan estimated premium rate increases to us sooner rather than later. While we all appreciate the calculations for the blended rate, what really is critical to us at this particular point in time is more in line with what's happening in the individual plans. And while I understand you can't give us anything exact, even an advisory rate would be tremendously helpful to all of us at this point. The other thing I would ask is if you have any great ideas on how we can communicate our differentials in calculation of health insurance premium rate increases, if you will, overall, between the district and OEBB rates. I don't know that there is a way, certainly, to do that, but I'm hopeful that we can continue our dialogue and potentially come up with some great ideas going forward. Next slide is just, I think, is my contact information. So, like I said, rushed through that very quickly, but looks like Reed has a question.
Yeah, Angie, thank you. My name is Reed Scott Schwabach, and I hear what you're saying. I hear your request for information earlier. I'm just curious. I mean, these meetings are public, and so all the deliberations are public. Has that information, not the information about the potential rate increases and the differences in the plans, has that been hard to access? Or tell me more about what the issue is right now with getting those types of rate indications early, because it is all public right now.
And Reed, I would tell you that I have individuals in OASBO that try to join in and follow the board meetings and gather information in order to disseminate it. I think part of the difficulty is that while the conversations and discussions obviously are open to the public, we're struggling a bit in determining whether or not, I guess realistically, whether or not rates by plan are going to go up in a range or fixed dollar amount, or fixed percentage. And so I think we're just struggling with trying to interpret, maybe the best way to say this, to interpret the information and then be able to disseminate it out better. And maybe it's just a matter of I just need to be more informed about those conversations, and I need to be involved so that I can try to share that out on a larger scale with my membership, because I'm not convinced that my membership necessarily fully understands or appreciates the rate setting process either.
Thank you, that's helpful.
Yeah, and this is Ollie, and Reed's correct. You know, I think this year, Angie, definitely we can provide, you know, like we've talked about, really close estimates, you know, by March, if not earlier. The last couple of years, though, have been really painful as far as trying to align the plan relativities. So there's been some different options that the board's had to work through that would really swing rates by plan pretty dramatically up until basically the final decisions in April. But hopefully, you know, I think, you know, now that we have the plan relativity straight, there will be a lot less kinds of the issues that you laid out in the presentation, which I really thought was informative. I mean, you know, I think we all bring different backgrounds and experience to this, and I've never really been privy to what happens after the rates are set, and that process that the districts and all the different associations go through. So
time for one more question or comment. Okay. Well, thank you, Angie. Actually, I would encourage you to stay tuned and listen to the next presentation, because of how we are communicating the early renewal progress may be a little bit easier to understand. So, thank you.
I will do that. Thank you.
All right. Well, Jenny and Brad.
Yes.
We want to give you enough time to get through all of this, so.
Sure.
But be mindful, please.
Sure. So it's Brad and I, but also Taylor, who I'm thinking is also joining us from WTW. So many of you, if you participated in this morning's CIO, got a chance to sort of virtually meet Taylor. Taylor's the newest member to our consulting team. She's a project manager and has been working with us on the OEB team for about the last 6 months, but she's been with the firm for about 6 years. So we'll all three tag team and see how that works. I'll kind of kick us off and sort of talk about what we're going to be going over in terms of the renewal. And then Brad will get into a lot of the detail behind the specific calculations, and then Taylor will sort of talk about each of the renewals and some of the plan design changes coming up. So just to set the stage, this is a preliminary renewal proposals from all of the different medical, dental, and vision carriers. I think several of the members of the board understand that we have a process that we go through where we look at the preliminary renewal positions. We consider some potential plan design changes. We talk about the impact to members, and then at subsequent meetings, we sort of refine the preliminary renewals, maybe learn a little bit more about some of the proposed plan design changes, and then we work towards finalizing all of the renewal positions at either the early April meeting, or sometimes there's a meeting towards the end of April. But in all cases, all the decisions and the rates are all finalized by the end of April. And I believe that OEB staff tries to publish those in early May, as soon as they're confirmed. Okay, so what we'll talk about today, we can go to the next slide, is the renewal positions. Just have a quick, a quick recap of our goals. The first one, all of these goals I think you've seen in the last meeting or two, but I just want to maybe take a minute to point out a couple things here. The first one, I don't know if these are necessarily in order, but the first goal that we have listed here is ensuring sustainable and appropriate rates for each plan design. And just maybe hearing some of the conversation that happened and that went on in our last presentation. I'll just remind the group that yes, over the last 3 years, the OEB board has worked to get to a place where the rates for each plan design are at a good and stable place. We do recommend looking at that and calibrating that about every 3 years, but this particular renewal that's coming up is not, we're not recommending doing that process for this year. So said another way, most of the preliminary renewals that we're going to talk about here are going to be applied equally across all the plans. So for instance, if Kaiser's presenting a 1% increase, that 1% increase is going to apply to each plan. However, if there are plan design changes that impact a particular plan more than others, sometimes it is prudent to apply the impact of that rate change to a particular plan, and we will try very hard to point that out as we go along. Here, there's not really anything in the preliminary changes that I would say, except maybe on the dental, when we get to the dental. So that's my preamble on the first one. The next are all, again, repeats of what we've talked about before. Ensuring a meaningful choice and array of plan designs for members to choose from is a key tenet of the OEB program. We're always considering plan design changes that can help improve the efficiency and underlying performance of the program. Certainly, the board is required to work towards a 3.4% growth cap, and the calculation method for that is very specific. So we will address that on one slide in this presentation, and the rest of it we've tried really hard to represent what's the actual rate change, incorporating all of the taxes and fees, just so that it resonates with everyone. And we'll talk more about that as we get there. And then incorporating any legislative changes. There are a few of those, but not many. And then ensuring that the changes that we're making are addressing health equity concerns. Okay, so I think at this point, I'm going to turn it over to Brad to talk about what's impacting the program.
All right, so before we dive into the nuts and bolts of the renewals and the numbers and everything, we thought we'd highlight a few of the key items that are expected to or are impacting the 2022 plan renewals. So certainly the first on the list is probably the largest, and that's the impact of COVID-19. We know that the 2020 calendar year has had substantial claim suppression, and that's really dropped down our experience period or our baseline claims that are typically used in the renewal. And we know that sort of suppression is not expected to continue into the plan year of 21-22. So there's a number of different philosophies that are used for projecting the expected costs into the new plan year. And so we have to kind of take some of those methodologies into consideration. And then in addition, there's another layer of saying, after we've adjusted for our historical claims that we've experienced, what do we think might happen in the future for continued delay or deferral of care, or will we have some pent-up demand? So that's kind of a pretty large one, and we'll talk a little bit more about that on the next slide in a little bit more detail. We also have the impact of the hospital reimbursement cap, not only in the primarily related to the implementation of the clarified rules. That's going to have an impact on our renewals this year. And then we also have kind of a use of the RSR funds last year for both the MOTA and Kaiser plans, and that does impact the final renewals as we use those RSRs to adjust up and adjust down the various rate positions for the 2021 plan year. So we'll look at that in a little more detail too. Any questions before we dive a little bit more deep into the COVID-19 impact? All right, so this page is really sort of more of a due diligence item, and it's at a high level going to offer a little bit of an explanation of how we're addressing the claims experience, and sort of to provide a little bit of a broader context around some of the methodologies the carriers might be using, and to provide a little bit of confidence that some of these methodologies are in line with best practices and so on and so forth. So we certainly know if there's one thing that can be said to be true this last year, is that the pandemic did have a material impact on our healthcare costs for 2020. Like OEB, many of our healthcare plans came in under budget due to that depressed or suppressed utilization, and that low utilization is not expected to continue indefinitely. So really that means that actuaries and underwriters in both the carriers and consulting firms and everywhere are going to have this challenge of projecting the healthcare cost forward, and how do we adjust this 2020 claim experience? And so far, there's really been two primary methods that have emerged in the industry. And the first of these is sort of called the completion method. This completion method does incorporate the pandemic experience into the projection. That's really its key differentiator. And it recognizes that at least some of the claims during and surrounding that pandemic event are relevant, reflects the current and ongoing underlying health status of the population and the utilization of services. In particular, prescription drug claims, I think it's widely felt in the industry that prescription drug claims were not overly impacted or suppressed during the pandemic and can be treated as normal. And so it does include all of that. As the name suggests, this method adjusts the pandemic impacted experience to a kind of a pre-pandemic or maybe even a non-pandemic forecast level. The adjustments are usually based on a blend of plan-specific, kind of historical experience, but also look at regional expectations and experience. So kind of in a sense, bringing that the pandemic experience sort of up to a forecast level and then moving on from there. So the other method is pretty straightforward. It's kind of known as the exclusion method. And as its name implies, this method does not include the pandemic-related experience. Typically, it will exclude all claims experienced after February 2020, which can be medical only, or in some cases, medical and prescription drug are both excluded. And this method essentially relies on an additional year of trend in the forecast. So, you know, the downside of this method is that it really doesn't reflect the actual claims experience in areas that may not have been particularly impacted by the pandemic. And, you know, we've heard about a lot of acute inpatient, cancer care didn't seem to be impacted, and it doesn't also does not reflect the changing of the healthcare landscape during the pandemic for things like specialty RX mix and, you know, the new drugs that we're seeing in there. So kind of our last bullet point here is Willis Towers Watson generally recommends or is recommending using the completion method for our future claim projections. All right, that was really technical, a little bit of due diligence. Nice job sticking through it. Any questions? All right, so we can move to slide 7, which is sort of the main feature of our report here today. And so this slide, as Jenny mentions, this particular slide is sort of our test against where are we sitting in the current renewal state relative to our 3.4% legislation target. And so all of the numbers on here from a renewal percentage standpoint are before the application of change in taxes and fees. So we can kind of see here that your eyes go immediately to the yellow box at 4.07. And so currently we are over our 3.4% renewal target. And so we'll take a quick look through our various medical, dental, and vision plans to see where they are and who's impacting that 4.07 position. So for MOTA, the MOTA plans currently are coming in at a 5.51% increase, which is over the target. Kaiser is coming in just a little over 1% on their medical plan. Delta Dental is coming in just a little over 2%. Kaiser has chosen to have a flat renewal on their dental. We'll talk a little bit more about that as we get into more detail there. And Willamette is coming in at just about a 0.5% increase before the taxes and fees. Motivision is coming in just a little under 4%. Kaiser Vision at negative 0.3%, and VSP. Can we go back to slide 7 for just a moment? And VSP is coming in on a before taxes and fees basis, not at 19.5%. There's an extra 1 in there that we had some version control on our fantastic storage cloud system. So that VSP should be negative 9.5%. And when we combine all those together, we're at about 4.07%. All right, any questions on that before we move to slide 8?
Yeah, this is Bill. What are your migration assumptions in that number?
So there are currently no migration assumptions right now built in. So this reflects the most recent census data that we had at the beginning of the plan year. We typically get a census one time during the year, and usually in situations where we don't have large changes in either plan design or disparate changes in pricing and such, we typically would leave the enrollment alone. So both the both the current and the next plan year would be the same enrollment.
Understood.
Yep.
Thanks.
Sorry, long-winded explanation.
Yeah, question here, Brad. So these are preliminary numbers.
Correct.
Which means they could possibly go up or down from here. Is that correct?
Correct.
In our experience, they tend to go down a little bit as we get closer. Would you agree?
You know, I think it really just varies. One of the largest impacts that we see is usually incorporation of a couple more months of data. So we move our 12-month data period from, you know, usually it's kind of a, you know, October to September, and we may move that to a December to February. And it really depends on how those 2 extra months of claims that we've added compare to the 2 months that we've dropped off. So that's really the key driver in there.
Okay.
But that said, I'll just add that at this point in time, the carriers do tend to be a little bit more conservative. But yes, it could go either way, but 9 times out of 10, it's not gone up, it's gone down.
Yeah. So kind of responding to our last presentation, this one page gives them an indication of where we're, approximately where we are. In each column, every plan offered applies to all of the plans being offered by that provider. So if I take Delta Dental, all of the dental plans at this point would go up 2.31%. And Kaiser Medical, all of the medical plans they offer would go up 1.06%, correct?
Correct. I'll take you just a half a pause though, if we advance to the next slide. So what the entities and members will actually see are the changes after taxes and fees, which are shown on slide 8, Jeff.
Okay,
but otherwise,
great.
your comments are all spot on.
Yeah, I'm just wanting to give our last presenter a summary kind of view.
Yep.
Okay.
Absolutely. Good comments. So right now, from a preliminary perspective, these are the rates that would, these are after taxes and fees, and we felt it was important to show those right up front. We know we have to measure against our 3.4% target before taxes and fees, but the after taxes and fees are what is actually seen by the entities and the members. And so we wanted to kind of move to that viewpoint for this slide and the rest of the presentation. So from here, we have our Kaiser at 0.87. Moda has dropped down from 5.5 to 4.77. Kaiser Dental is at 0. Delta is at 2%, and Willamette is at 0. And Vision are all either very low or negative, with Kaiser coming in at negative 0.6, Moda just about 1%, and BSP at a negative 12%. Any questions on that?
Yeah, this is Tom. This though does speak to the concern that I just heard in regards to what certain districts see. If you are in the Kaiser footprint of the state, you have the potential of having lower cost structures than if you are outside of that. And we're seeing this 4% or almost 4% difference between Moda and Kaiser from the standpoint of the rate increase. I know that we're not set yet, but that speaks. This is an area that I hadn't thought through enough before, so it was so helpful having that most recent presentation by Ms. Peterman around what individual districts see.
Absolutely. Good comment. Any other questions or comments on slide 8? All right, we can move forward. I believe we'll be advancing to slide 10 if you're not following along on the visual. And this is this slide kind of is intended to show the leveraging effect of use of the RSR in the 2021 renewal and the effect it has on the 21-22 renewal. So lots of years and numbers in there, but it really says that it's a reminder that we reviewed the concept in our last meeting, but this is sort of the actual application of the renewal. And so in our 2021 renewal, as a refresher, we actually mitigated the decrease to the Kaiser rates by increasing them a little bit and adding to our RSR funds. And so, had we maintained that lower rate last year, we would have had an increase of 3.61 to get to our current projected plan costs. So it's worth looking at this to note that, while our rates are changing by 0.87, our plan performance is really changing at 3.61. So that mitigation there, or the buy-up of the RSR to increase the rates last year, is really causing some artificial low percentage increases. So really, that's what we're going to see from a rate change perspective, and that was the intention of the RSR funds. But thinking from a plan performance perspective, we're at about 3.6%.
This is a very important slide to remember.
Mm-hmm. Yeah, and so in one sense, this is a good illustration of how the RSR was intended to work, to sort of say, hey, we're going to bank some of that low volatile renewal that we had last year of negative 5%. We banked a little bit of that, and now we're able to use it this year to bring down a higher renewal. So this is an example of the RSR providing some level of rate stability. Any questions on that? All right. So
just a comment. This does not, though, lower what's in the RSR currently. So the 15 million that's in the RSR for Kaiser Permanente is not affected by this. It just means that by doing this, we're not adding to it.
Right. That's correct. Yeah. For the 2021 plan year, we actually are adding to it.
Right.
So, but this is assuming that there will be no additions or subtractions to it in the 21-22 plan year. Does that answer your question, Tom?
Absolutely.
All right. Okay, so we can move to slide 11, and this gets into a little bit more of the details and some of the nitty-gritties on the Kaiser renewal. One of the important things, and we just have the detail, first of all, about our preliminary renewal of 1.06, the application of the change of taxes and fees to make it very transparent, and the percent increase after taxes and fees, as we've seen. One of the key things on the renewal here is that Kaiser chose to incorporate the impact of the COVID-19 claims into their underwriting trend. And so because our claims were so low during the 2020 year, and we don't expect that to happen again, we need to have a higher than normal or higher than market trend to bring those claims back up to expected levels in the 21-22 plan year. So as we look at the underwriting, that it looks a little bit funny. And so, although, mathematically it's equivalent from, if you take your calculator out and punch things, it could be equivalent. It just makes it more difficult to isolate the impact of COVID-19 from the underlying trend and plan performance. So I will also note this approach is consistent with other Kaiser plans and regional underwriting methodology. So this isn't something that's being done specifically for the OEBB plan. All right, so the Kaiser renewal did use paid claims experience from October 19 through September 20. And it's worth noting that there was a $4.9 million individual claim, which was pooled out at the $725 pooling point level. So very similar to, a more traditional stop loss type of pooling. Administrative costs were increased at about 2.4%. And right now our projected RSR fund balance as of October 2021 is right around 15.4 million, or approximately 8% of the annual Kaiser premium. Any questions on that? All right, so we're going to now turn that back over to Taylor to walk us through some of the plan changes and such.
Perfect. Thank you, Brad. So we will kind of walk through here first one of the proposed plan changes that Kaiser has put forth this year. And really, it's not a plan change so much as a plan addition. So you'll see there kind of the second to the left. yellow column with the proposed plan there is a $1,200 individual deductible plan that Kaiser is proposing. This is not an HSA qualified plan. So it's not your traditional high deductible with HSA plan. This would function similar to a PPO. And really it's to, kind of help add some choice for members. You can see there in the top row the enrolled subscribers on each of the current plans, with the majority of members falling under Plan 1. But I will say for Plans 2 and 3, where there are deductibles, we did see some members even in the 2019-2020 plan year when COVID was a consideration hitting their deductibles. So for Plan 2, we saw about 830 individuals hit their deductible, and about 11 families. And then for the Plan 3, we saw about 550 individuals and about 320 families hit their deductible. So just something there to consider. There's obviously some members that are hitting their deductible. May be nice to consider adding some additional choice for members. And then the very bottom row there kind of shows the illustrative composite rate, so you can see how that rate stacks up against those other plans. It's about 4% lower than that $800 deductible plan, Plan 2.
Yeah, I'll just jump in with a quick comment here. So a couple things. These are illustrative, right? So even though we're very anxious to know what rates are, these are based on, first of all, the preliminary renewal, and they also don't include the OEB admin fee. So these are just to give you a sense of where the premium position would be relative to the other two Kaiser plans. And then, so if the board is interested in moving this concept forward, obviously we'll keep bringing this back at the next board meeting, and we will likely incorporate some sort of a migration assumption of people, Kaiser members most likely selecting this particular plan, to show how the addition of this plan might help the overall target 3.4. Yeah. Okay.
Thanks, Jenny. All right. So if there's no questions, I think we can go ahead and move on to the next slide. Perfect. Thank you. So another major initiative that Kaiser had that was with OEB was during the 2016 RFP process. Kaiser proposed about $750,000 in funds that were to contribute to wellness and innovation for OEB entities. The majority of these funds have, Okay, want to go back maybe or forward. Oh, sorry, let's go back 2 slides, I think.
We can chat.
All right. Oh, perfect.
And I think just one more slide back.
Move forward.
Perfect.
All right. Thank you so much. Oh, one more. Sorry. Slide 13. No problem.
No.
Thanks, Rose. So those $750,000 in funds have been primarily used. There is still about $110,000 remaining, of which Kaiser has proposed some options. But to back up a little bit, of that $750,000 that has been used, a large portion of it has been used for these wellness space mini grants, which are for the OEB entities and have covered a variety of things like paint, carpet, wellness spaces for teachers and staff, really a wide variety of use there for those grants that were awarded. There was also the flu shot clinics that were funded and are slated to be funded for the upcoming year, as there's some additional funds still available for that. And then there was also the funding of the Total Brain Resiliency app, which was available for all members. So Kaiser has proposed continuing the wellness-based mini grants since those have been so well received by the OEB entities, and also considering continuing to promote those flu shot clinics with the use of those remaining funds, and can also consider using some of the RSR funds to support some of those programs. Any questions there? Okay. So moving on to the next slide, as Jenny mentioned at the beginning, it's become an important topic of conversation that health equity is kind of weaved throughout OEB and the processes that are involved in decision making. So as part of this year's renewal process, we did ask the carriers about what they're doing in the world of health equity and diversity and inclusion. So I just wanted to highlight a few of the things that Kaiser brought forward. They recently developed a dashboard to evaluate gaps in care for the members that are being served in their mental health and addiction medicine services. They are also currently in the process of updating provider biographies to provide more information around culturally competent and culturally specific care needs, and to get members to providers that they feel comfortable with. There was also the creation of the Equitable Care Health Outcomes Advisory Board, which really looks to focus on healthcare disparities. There was also very large impact investments and grants supported to support local businesses owned by members of underrepresented groups. Sorry for that. And then lastly, there was the RISE program, which is the Resilience in School Environments, which really focuses on promoting the emotional and social health of K-12 educators and staff. So lots of great initiatives put forward by Kaiser that I'm sure entities appreciate. All right. And then I think I will go ahead and pass it back over to Brad to talk about the MOTA renewal.
All right, so sounds good. So we're going to start out with a similar but somewhat opposite illustration for MOTA of our RSR funds leveraging example. So in this example, recall that the board chose to mitigate the MOTA increase for the 2020-2021 plan year by using some of the RSR funds. So in this case, we decreased the premiums a little bit more than the renewal was, and ended up with a renewal that was at 4.77%. Had we not decreased the base renewal last year, we would have actually been running at about a 3.76% renewal, which is a little bit closer to the Kaiser baseline renewal without use of RSR funds. So, just really a good example that sometimes when we use those RSR funds to decrease our renewal, we can end up with a renewal that's a little bit leveraged higher. So opposite of the Kaiser example we just saw. Any questions or comments on that illustration there?
The other important slide that we need to remember.
Right. Yep. Yeah. So just, is important to remember that about 1% of that MOTA renewal is being driven by the use of the RSR last year to buy that renewal down. Okay, so moving on to slide 17. In this slide, very similar to the Kaiser, we have a quick just recap of our renewal position, 5.51% before taxes and fees, about negative 0.74 change in taxes and fees down to our net of 4.77. So MOTA is using currently a 5.18% combined medical RX trend, and that breaks out into about a 3.3% medical trend and a pharmacy trend of about 12.4%. In addition, there is a load of 0.3% for anticipated provider behavior changes related to the 1067 hospital cap. There's an explicit COVID margin of 1%. We talked a little bit about the need not only to adjust our historical claims, but to project the impact going forward. MOTA is projecting that there will be an excess, I guess you could call it a net pent-up demand of about 1%, and then inclusion of an additional 1% general margin on top of that. Our claims experience went from October 19 through September 20, but this was on an incurred basis. So when the services were actually used by the members, as opposed to when they were paid by the plan. So we had paid data through November 2020. Administrative costs are increasing 3%. We have an included mandate benefit change of about 0.08%. And it is worth pointing out that MODA used a completion method to adjust for those COVID historical claims. As we talked about kind of at the start of our presentation, and Willis Towers Watson is in agreement with that adjustment methodology. With that said, some of the COVID adjustments and other general assumptions are still under review with MODA. So the projected RSR balance as of September 2021 is currently expected to be 26.1 million, which is approximately 4.2% of premium. All right, and with that, I think we turn back to Taylor.
Brad, I had a question, if I may. So I noticed there's a difference between the administrative cost increases between MODA and Kaiser. What are some of the factors that are going into that, and why would there be such a big difference? Well, I think the difference is percent, so if it's big or not, I mean.
The 0.6%, 0.4 or 0.6%, I'd have to go back and look at the Kaiser.
Well, there's a difference in administrative cost increases, and so what are some of the factors that are going into that?
So just as a refresher on the Kaiser, we reported Kaiser administrative costs increasing 2.4%, and MODA's increase at 3%. And I think that's really just the estimated cost of doing business and administering the plan of each of the two carriers. And, frankly, each of the two carriers has, very different methodologies of trying to estimate what those administrative costs will be going forward into the future. From an actuarial standpoint, the 2.4 is not too different from the 3%. Usually, from a market perspective, we see a 2 to 3% increase. I think we would need to get the carriers to kind of more opine on why and what's driving that increased percentage. Really from our perspective, we really see that just kind of more as a PEPM, type or PMPM type number that's put in there. So, and that's something that we do discuss with them a little bit, the appropriateness of that increase, particularly if we see it going above anything from a market perspective.
Thank you.
Question, does this possibly represent the addition of MODA 360 administration?
No, I don't believe so. I believe that administrative cost was in there last year, and there is an offset. I want to be very clear, there is an offset for that cost, from a claims perspective. So MODA is expecting to at least have a claim reduction, at least in the amount of that, the MODA 360 administrative cost. So that, and I believe the W2W team can keep me honest, but I believe that cost was held flat, the MODA 360 cost year over year.
So that would be flat in the total dollars, but admin could possibly go up and claims down to offset that.
I think the PEPM was held flat from on the MODA 360, I believe.
It'd be good to understand that.
Mm-hmm. Yeah, we can certainly do that.
Another question? Reed, you're clear now?
Clear as mud, right?
Well, no, there you go. Thank you. I'm trying to watch the hands.
I'm good, thanks.
I have a quick question, Jeff. This is Ollie.
Yeah.
So the board needs to get down to 3.4% via the composite rate by law. So actually, the federal taxes and fees are going to be benefiting school districts, local governments, our employers this time. So similar to this last renewal, it looks like almost 1%. Is that correct?
That's generally correct. Yes. The Kaiser tends to have lower tax burden, and so their impact isn't quite as much. But yes, on the MOTA piece.
So the fact we don't have to count it in the calculation, when it's 1.5% more, is a good thing. But now we don't have the benefit of using it to get down to 3.4%. We still have to get down to 3.4% without the help of the taxes and fees. So employers would see, close to a 2 point something renewal when that happens. So, okay, thank you.
To the district.
Go ahead. Yeah, I was just going to say, I mean, obviously the goal is to have all of the renewals by themselves be 3.4% or less. But it's just going to happen that every year each carriers might be a little bit off of that.
And it is noted that this is a very difficult pricing year as well. So
thank you very much.
Mm-hmm. And I will say, just as a note, we are working with both carriers, regarding, assumptions, methods, kind of really doing a pretty good deep dive into the individual pieces of the renewals, as well as keep in mind that we will have, 2/12 of our experience period, or 1/6 of our claims experience will, change probably in the next renewal. So that will also drive some level of change. Hopefully, as Jenny said, hopefully for the better, but the actuary is not going to guarantee that.
That's right. Well, I know we're going to talk about plan design changes for MOTA on the next slide, and I'll just Taylor's going to walk through all of them. But yeah, I just wanted to start off by saying, number one, these are all plan design changes that, for the most part, MOTA has put forth for considerations. I think there might have been a couple that we asked for. The rate impact, again, are all preliminary, so we're still working through the rationale and the calculation of those with MOTA. In general, we agree with the concepts of all of these benefit changes. It's just the cost impact and the value of those changes. Those are the things that we're still working through. But I think the goal of this is we'll give you a high-level review of each of these benefit changes. Some of them were discussed in CIAO this morning. And if there are more, some of these changes that you want to hear more in depth from MOTA about, we would want to invite them to come next month and provide a little bit more detail. That's the preamble. So Taylor, you can go ahead and take us through some of these changes.
Perfect. Thanks, Jenny. Yes, so several changes we have proposed this year. So I'll just start knocking through them. So first on the list is something that has historically been done, and it is an indexing of the maximum cost shares on plans 1 through 5 with MOTA. This is not necessarily the out-of-pocket, but it is the max cost share that also incorporates the ACT copays, RX copays, and things like that. And as I mentioned, just historically has kind of ratcheted up with the federal maximums, so recommending that again this year. For plans 6 and 7 that are the high deductible plans, MOTA is recommending indexing up those out-of-pocket maximums, similar to kind of what's happening on plans 1 through 5, but because they're high deductible plans, they are the out-of-pocket is kind of the measure there. So recommending indexing those up along with federal maximums as well. The next change there, Brad touched briefly on as part of changes that were incorporated into the renewal already, because this is a legislatively required item. This is State Bill 526, which provides home nurse visits for newborn care in very specific circumstances where social determinants of health is taken into consideration. Additionally, it needs to be in a county where the Family Connects Oregon program is already implemented. And that was, again, already included in the renewal. It was a little bit less than 0.1%. The Next change on our list is House Bill 2560. So today, if you receive a positive fecal occult blood test, you receive your follow-up colonoscopy is covered as preventive. This change is proposing that follow-up colonoscopy just be covered under the regular medical cost share level and not covered as preventive, just for plans 6 and 7, out of concerns to make sure that they remain compliant with HSA qualified high deductible rules. Impact of that is expected to be negligible. And then the last change on this page is around mental health parity requirements, and MODA is recommending that the ABA, Applied Behavioral Analysis Services, that are often used to treat patients on the neurospectrum, be covered at the medical cost share level rather than their kind of regular primary care doctor cost share. And the reason for recommending that change is, again, it maintains compliance with mental health parity, but it also just reduces some member confusion and some administrative burdens in making sure that those claims are processed correctly. Any questions on any of those before I move on to our next set of plan changes? All right. Okay, so a couple of these ones, if you attended CIAO this morning, you may have heard some information on them, but I'll go ahead and start by talking about the advanced imaging steering. And this really aims to utilize the MODA Health Navigators to steer members that are receiving kind of those high cost advanced imaging procedures, your MRIs, your CAT scans, aims to use those health navigators to get those members to go to a more cost-efficient place to save money both for them and for the plan. MODA is proposing initially that this plan would be voluntary, or that this program would be voluntary, and started as a pilot with just a few high-cost facilities to really understand how best to communicate the program and how members receive the program. And at this point, there is no cost impact estimated for that. Next on our list, we heard a lot this morning about how costly emerging cellular and gene therapies can be and are expected to be over the coming years. So MODA has proposed utilizing a prior authorization process to steer certain individuals that would need these therapies and treatments to centers of excellence. The centers of excellence have obviously performed a lot of these procedures. These procedures can have, very costly and aren't always successful. So part of this program also would include a reimbursement if the treatment was unsuccessful. So no cost impact at this time. Estimated with that, it would probably be a very, very small subset of people that would be affected by that, but again, a very highly specialized procedure that probably good to consider a center of excellence for. Moving down the list is musculoskeletal prevention. MODA is proposing utilizing the OEBB wellness advisors to provide ergonomic assessments. We know from other presentations that kind of early assessment of those ergonomic factors can help delay or prevent further care or more expensive care in the future. No cost impact associated with that. Next on our list is cost share on generic specialty medications. So today, if a member is on a specialty medication, they're obviously, generally speaking, in a higher tier, have a more costly medication. And this really aims to move them to the generic when that specialty patent has come up. Sometimes members on specialty medications utilize manufacturer coupons, and that may reduce what their out-of-pocket cost is. So this just also, again, aims to promote that generic first strategy by incentivizing the member with a lower copay compared to what maybe their specialty copay might look like without a manufacturer coupon. Additionally, for those members that did move to a generic, it would likely be a cost savings to them, but also to the plan. And then next on our list is disease management for pain. So we know MODA has processes and strategies in place to help with the overprescribing of opiates. But this really focuses on managing pain from multifaceted aspects, addressing the psychological components, the physical components of pain, and not just focusing on opiate prescriptions. The estimated cost impact for this program is about 0.01%. There are more individuals kind of involved in managing the care and management of those individuals in this program. And then last on our list for this page is our coordinated specialty programs for behavioral health. And what these are very intense and different behavioral health programs that are different than your traditional office visit model. And oftentimes these are programs that are evidence-based, typically provided by community mental health programs. They're a bit more flexible. Often you'll see youth in transition or youth in severe crisis, or maybe a youth that ends up in the emergency department and needs behavioral intervention. This might be a situation where this program would come into play. So kind of focuses on some of those members that might have a greater need from a behavioral health aspect.
And I know MODA recently implemented this for their book of business, and I'm not sure if these are also covered on the CCO program, but it's really interesting, and it might be nice to hear from MODA about some of the specifics on this, but it's a nice added benefit for those who need it.
Yeah, and Jenny, yes to both of those, covered on our book of business and under the CCO. And we would welcome the opportunity to come and discuss it more if wanted.
Yeah, and this is Tom. We haven't discussed it at CL, so I can't give you any recommendation from the CL group. I don't know if this represents actually something new versus an increase in utilization. So when I looked at this initially, I was saying, shouldn't this just be included in what your claims assumptions are? But I realized that we haven't really had a chance to discuss it. So if we could bring it, if you want, we could bring it to CL.
Yeah. Time check, we're closing in on 10 minutes left.
Okay. Sounds good. All right, so we can move on to the next slide here, unless there's any other questions. All right, so we know that we have our ACT procedures, our alternative copay tier. So MODA is proposing an updated procedure code list for this. It has not been updated since 2016. So that would include some addition of new codes and removing old codes. The code list is still something that is being finalized. So, obviously the pricing impact there is also preliminary. And more information will be coming on what those procedure codes are. The next on our list is gender confirming facial surgery. We spoke about this a little bit in CL this morning, and MODA is recommending covering gender confirming facial surgery with an estimated rate impact of 0.2%. And really kind of looking to align with WPATH guidelines, as well as address some potential legal issues seen in some other states. Moving down the list, we have the MODA 360 dental integration. So this really would focus on providing a total view into members who have both MODA Health and Delta Dental, really integrating those care records, working to close gaps in care, increase preventive utilization on both sides of the picture, and really kind of take care of that whole person. Next on our list is the Chronic Kidney Disease Management Program. Pricing is still being finalized on this, but this is really going to be using predictive analytics and other intervention support to help intervene with kidney disease earlier and evaluate for possible home dialysis and really try to either mitigate the cost or the progression of that disease. And then last on this slide is our musculoskeletal steerage. So MODA is currently in conversations about partnering with a virtual physical therapy provider, which we know from other meetings, we do see some value in that virtual physical therapy option and potentially preventing or delaying more intense musculoskeletal treatments. So pricing on that is also outstanding. But if we kind of total up all of those changes that we just reviewed on the last 3 slides, obviously excluding the ones that are to be determined, we're ending up just a little over 0.25%, 0.26% total impact.
Okay. So I absolutely do not want to minimize MODA's efforts in health equity, which is on the next slide. But I think in the interest of time, I would like for us to be able to touch on the dental and vision renewals. So I think, Rose, let's just move forward to slide 24. I don't know if you want to chat about these, Tanner. I'm just like, yeah, here they are.
Perfect. So, yep, as you can see, and as Brad kind of alluded to earlier, here's where the dental renewals ended up. We are just over 2% for Delta and flat for both Kaiser and Willamette. I'll go into more details in the next couple pages, but I will just kind of highlight that Kaiser and Willamette tend to have more similar models, so not so shocking there that they ended up at similar renewal positions.
And just maybe to add color to that, by having similar models, that just means they're, a staff-based model. So their costs are pretty fixed in terms of their, well, on the medical side too, their hospitals, their facilities, and then they pay their physicians a salary, right? So it's a little bit different than the fee-for-service model, where we truly are trying to project or estimate what are going to be the costs, what are going to be the utilization and unit costs of the dental procedures in the upcoming year. So it is a little bit different, but all that to say, these are still preliminary.
Mm-hmm. Thanks, Jenny. So looking at Delta Dental or MODA's components of their 2.05% renewal, there is an increase to the administrative fee of 3%. Similar to, medical, 2 to 3% is something kind of just cost of doing business that we do tend to see. We saw Delta use a 3% trend. They did use an explicit COVID margin, again, kind of anticipating that either deferred care is coming back or potentially deferred care has become more intense care. General margin of 1%. They did use the completion methods similar to medical that Brad talked about earlier. So they did use that pandemic experience and then kind of forecasted it up to what might be expected in a non-pandemic year. And then the change in the federal insurer fee there. Moving forward. Perfect, thank you. MODA has proposed adding one additional EPO plan design. So the first 4 columns, or really the first 5 columns there, plans 1, 5, 6, and 7 are the plans that are in place today. Plan 7 today is an EPO. And then the 3 plans on the right, new EPO A, B, and C, are the options that MODA has proposed, just picking one of those 3. So really the differences lie in the benefit maximum or the deductible. Certainly the $2,300 deductible would be, would increase the max for those members that are hitting their benefit maximums in a year and may be something members would have an appetite for.
So here's where, it would be helpful if if any of you have initial feedback for us about which of the three to move forward for consideration at the next phase, we'll just go ahead and toss out our recommendation that, if the goal of the new plan is to provide members with an enhanced benefit maximum to keep up with dental costs, then the EPO Plan C certainly provides visually members with a richer plan design, even though the network is smaller than the Premier network. So that's, I don't know if any of you else have feedback on that.
Okay.
C.
No.
We've got a C. All right. We can go ahead and move forward. And then an additional plan change that MODA has proposed would be adding preventive first on plans 1 and 5. And what this does is essentially most class 1 services that would be considered preventive would not count towards that annual benefit maximum. So it would really kind of stretch those dollars further for the members in plans 1 and 5. But kind of to Jenny's point earlier, if there is an appetite for a higher maximum in an EPO style plan, that plan C might be the option to look at. And then the rate impact for that is if we were to add the preventive first benefit to plans 1 and 5, the overall rate impact is 3.13% in total, but it does vary by plan what the actual rate impact by plan is. So that is different than the renewal. Any questions or comments there? Okay. So looking at Kaiser's dental renewal, they did come in with a flat or 0% renewal. Kaiser took the stance this year on their large commercial groups that were underwritten after June 2020, in most cases to receive a rate hold, and which includes no change to the administrative fee, and Kaiser also did not propose any benefit changes for this renewal. All right, we'll go ahead and move forward. And then Willamette Dental's renewal, again, flat or 0% renewal. The trend that they're using as an organization is 5.9%. I know a component of that has been the PPE or the personal protective equipment that they have used in their offices during COVID. They did represent the change in federal taxes, and then there was also a COVID adjustment made. And then there is currently a projected RSR funds balance of about $880,000 that could be used to offset any future increases. Any questions there? Okay, go ahead and move forward. We know that increasing preventive utilization has been kind of a hot topic for the dental plans, especially for Kaiser and Willamette, who tend to have slightly lower preventive utilization on their plans. So we did ask them to price out changing office visit copays for preventive visits. With the way that Kaiser and Willamette have their models set up, you unfortunately can't change the copay just for preventive visits. It would just have to be a blanket copay change. So for Kaiser, if we were to change that $20 copay to a $10 copay, it would have about a 2.06% impact on the renewal. And then for Willamette, if we change that from a $20 copay to $10, it would be about a 2.75% impact to the renewal. One thing that Willamette Dental Group did agree to administer would be waiving the copay for any OEB members, any OEB Willamette Dental Group members who have never had a dental visit before. And that would have no impact to the renewal. The claims would just flow through for those members. Any questions or comments there?
That's a head scratcher one. Being that I'm wondering for our members, is it $10 that's stopping them from going to see the dentist, or is it you can't go at night and you have to take time off from work? Really, which is it that prevents dentist visits?
Yeah, right.
That's true.
Okay, so I will go ahead and talk through the vision renewals really quickly here. Go ahead and move forward one more slide. Perfect, thank you. Actually, I think this is the last slide. So just a quick overview. Kaiser's vision renewal ended up at minus almost 0.6, minus 0.59%. Kaiser's vision plan is community rated, so it's based off of their full experience, not just OEB's experience. MODA's plan came in just about a 1% increase, but important to note that the trend that OEB experiences with MODA is about 4%, so a good renewal there. And then finally, about a 12% decrease on VSP, and those were initially guaranteed for 4 years and have been guaranteed for an additional 4 years. So just important that the volatility there does, at least in part, it can be attributed to that 4-year gap in between rating times, whereas MODA and Kaiser are typically rated every year. Any other questions? All right.
Okay, thank you.
Thank you.
These are always long, but they have to be, we have to get the process off to a good start. Any general questions regarding the entire presentation by board members? See, I don't see any hands up yet. Okay. All right, well, we're scheduled for a break right now. We're not too far off the mark, so let's reconvene at 3:20. Or am I cutting you short here?
You know what? I am so sorry. I actually, I misspoke. I thought that was our last slide. We have just 2 more slides, and I'll just focus on the next steps here. Just this one.
Okay.
Sorry about that. Thank you. Jenny, do you want to jump in here?
Well, really, the next steps are to, bring forth. Typically, we would try to finalize the dental and vision renewals at the next meeting in March. So we need to have a good sense of what those plan design changes are that you may or may not want to implement. So that could also bleed into April. We will also be bringing you the EAP and COBRA renewals next month. And then in April, we typically, work to finalize both the rating positions from the carriers and the final plan design changes.
One thing that I would ask for myself is on the dental, we are frequently asked to kind of reduce choices, but I would ask that we have Dr. Barrichello kind of talk to us about why it might be good to add another dental plan in the preferred EPO, PPO, that network, and to help us make a decision. Because I think there are some quality, cost, and access issues that we should consider on that.
Okay.
Is that all right with the rest of you? Okay, implied consent, right?
Sure.
Sure.
Okay, so still back in 7 minutes.
Hey, Jeff, back.
Yes.
Just saying I'm back.
Oh,
Hey, Jeff, I'm back.
okay. Let me swallow. All right. Thank you all for being prompt, keeping the pace up. Looking forward to this. Unfortunately, we couldn't get through this last time, but we asked some of our board members to give us their insights on social determinants of health. And JJ Reed and Sue Ricky Smith and Tom. So different perspectives from which is part of the strength of the board. So I think it says Josephine County, so that means JJ leads off. That's assuming JJ's back.
Actually, I think JJ had to leave, didn't he?
Okay. Reed, are you ready?
Yeah.
Let's, Rose, can you advance the slides, please?
He said he would come back.
Oh.
At least
Okay.
that's what he said in his chat.
All right.
I can advance the slides to, I think, Reed.
We'll give him 30 seconds. Oh, okay. There we go.
Do you want me to go ahead and present, Jeff?
Yeah, please do.
Okay. Well, good afternoon, everybody. I'm Reed Scott Schwabach. I am not a health professional. I'm not even a health teacher. I'm a Spanish teacher. But I put together this presentation for you based on information that we have around the social determinants of health of educators and tying it to the work that we do at OEA. So, and Rose, if you want to go to the next slide. Everything that we do is grounded in our students. And our students are the focus of the policy work, the membership work that we do. In order to create good, healthy schools, we're creating good learning and teaching, learning and working conditions for both educators and students. So I wanted to start with our students in the forefront because that is why we do what we do, and that is why we exist. When we think about, and this is the next slide, Rose, when we think about the social determinants of health for educators, the CDC has identified 5 areas, and you can see them on the slide. And there are a number of these areas. In fact, I would say all of these areas intersect the work that educators do. Obviously, as a labor union, we are deeply embedded in the work around healthcare. Education access and quality is also something that we work on because it has to do with how our communities are accessing quality education and what kind of services they can access. And social and community context are what schools are embedded in. Our schools are deeply tied to the communities that they come from, and this is an interest to us as well as a union. And then the CDC has also identified economic stability as one of those social determinants of health. Obviously, when we work for compensation and salaries, we're working towards economic stability for not only our members, but also for the communities that they live in. And then that last one, neighborhood and built environment, has to do with not only the neighborhood infrastructure, but then also the environment people live in. So do people have access to clean air? Do they have access to clean water? And these are issues that we know if we don't take care of them, our students come to school sick, they come to school with asthma, with other health issues, and our educators also are at risk if their environments that they're working in are not healthy. So these are what the CDC has identified, and we actually work, all in all of these areas as a union. Go to the next slide, Rose. One of the really, really important type of data that we have been able to collect on how educators feel about work. And so if we think about both the sense of, the emotional sense of the workplace, but then also some of the factors that overlap with health factors of safety, health factors of good ventilation, is something called the TELS survey. And some of you might be familiar with this. It's been around for a number of years. It was actually discontinued in the last couple of years, and we're working with ODE on bringing it back because it is one of the best sources we have for knowing how educators are feeling at their work site, and then also for the longitudinal data of, are we making a difference? The TELS survey has been used in Oregon over 6+ years, and so we have some really good longitudinal data that's telling us about what the impacts are at the local level with employers and employees around things like, how are we making sure that schools are safe for educators and for students? How are we doing providing the resources that keep educators in the field? And you can see that in 2018, overall, people felt like their school is a good place to work and to learn, but that we had some issues around environments that felt safe. And so the TEL survey is something that we hope to bring back. We think it's an important tool as we think about social determinants of health, and also for a metric for whether or not the state is making progress on those goals that we have around increasing educator retention, increasing educator support, and increasing the quality of the schools our students are in. Rose, if you go to the next slide. This slide I was put in here so you can see a little bit about educators' finances, since we know that financial stability is a social determinant of health. And we are deeply concerned about, in particular, that average beginning educator salary. And this is around teacher salary. OEA has ESP members as well as community college members. But the data that came from the OSBA survey was focusing on K-12 licensed teachers. And you can see that that the average beginning salary is fairly low, $38,000, just over $38,000. This is a concern because we know that most educators are entering the profession with a high amount of student loan debt, since it is required to have most educators are doing their license through a fifth-year MAT program. So as we think about social determinants of health, really making sure that educators have robust compensation packages. We heard earlier from the OASBO presentation around compensation packages. These are factors that really do make a difference as educators are looking at not only where do they want to work as far as the districts in Oregon, but also do they want to stay in Oregon. And so having Oregon salaries be competitive, having the compensation packages be competitive, and then educating incoming educators on the importance of asking about that is something that we're concerned about. We had last weekend a new educator conference. It was for anybody who was in their first 5 years of the profession, and also for our, what we call the aspiring educators, our student educators who are still in college. We had a financial wellness session with 65 attendants. We had a lot of folks who were interested in financial wellness. And financial wellness and financial knowledge is an area that a lot of educators don't feel particularly confident about. So part of our work as a union, but also part of our work as a member of the community, is just helping people feel more confident asking questions about finances and knowing how to do things as simple as making a budget. You'll see that the salary wage for our education support professionals, our ESPs, is also pretty low. And what we know about our ESPs is that they really rely on healthcare benefits they can get. Most of the members in OEA who are ESPs report that they actually see the healthcare compensation as a really, really vital part of their compensation package, and that they are working more for that healthcare benefit than they are for the salaries, since salaries are so often low. We're also concerned about that four-year degree cost. You can see that in the last year, we've had a 5.2% increase. And so as educators are looking at both their own finances, but also as students are looking at, do I go into education? That question about, can I afford to work in education, live in my community, is a really pertinent one. And we are concerned about educator recruitment. Retention is also an issue, but the recruitment, how do we get folks to see education as a vital area where they can have a career that allows them to be both fulfilled professionally, but also support their family? It's something we spend a lot of time thinking about and working to help correct, so that we have a robust population of people who see education as a potential career. Rose, if you want to go to the next slide. In general, on the next slide, I put together kind of the 4 or 5 buckets of where OEA spends the bulk of our time. Obviously, here I am on the OEB board, so quality healthcare is a huge concern for us. But we also spend a lot of time on professional development. This might be something that not everyone is as aware of. OEA provides professional development through both the virtual and, when we can, in-person world. It's an area that we've been building up. We've had a lot of folks who have been using OEA to be able to get the professional development units that they need to renew their license. We hosted a community college professor-led virtual tips for virtual teaching seminar that was for community college folks as they were transitioning into the virtual world. And it was so popular that we're doing another round. It's an 8-week course. People are actually getting college credit for it. But that professional development and empowering educators to share what they know, and then also see the areas that they feel are important reflected in the union that they are a member of, is something that's really important to us. And obviously that connection and sense of empowerment also comes into play when we are at the bargaining table with salary and compensation, and talking about why it is we need to have compensation packages that cover important things like healthcare. And community issues are another huge part of our work, because we know that the communities our schools are located in, the quality of the schools and the quality of the communities are deeply tied together. The next slide is just a little slide that looks at how our professional development really hits those four areas of the social determinants of health, that quality of community, the financial stability, the ongoing learning, and that connection. And the next slide has a sample calendar screenshot of the professional development that we've been doing. This is professional development that is available to both OEA members and non-members. We charge non-members a small fee, but if they are eligible for membership and they sign up, then they can access it for free. And the last slide, second to last slide, is just another snapshot of some of the work that we've been doing to help members connect. We have a new program called the NEON program. It's the New Educators of Oregon Network. It's open to all OEA members. And it's designed to help members connect with other members who are going through similar experiences. In this case, the experience of being a new educator in Oregon. And we also have a program called Diversity Sparks, which is designed for our BIPOC members, our Black, Indigenous, and people of color members, to connect. And this is a program that was started with grants from NEA, and it is statewide, as NEON is also statewide. And Equity Sparks has been connecting members who identify as Black, as BIPOC members, to both get to know each other, to decrease isolation, but then also to look for ways that they can influence what the union does, influence what's happening in their school districts, and it's becoming a tremendously valuable and powerful membership group within the structure of our union. And then the last one is that NEA has a program called micro-credentials, and this gets back to that professional development, but also to the empowerment. And the micro-credentials are online. They're led by members. Some of them are self-directed, and some of them are classes that people sign into. And the curriculum has been written by other educators. In fact, a couple of Oregon educators were paid by NEA to write some of these, and they are both for licensed educators, and then there's a whole set of micro-credentials that are just for ESP members. One of the things that we find is that education support professional members oftentimes don't have quality professional development, which leads them to feel like they are disempowered, not valued in a school district. And so we see quality professional development that is made specifically for the types of jobs and types of situations that education support professionals are encountering. It's a really key piece in helping people feel connected and empowered, and also giving them access to skill development. So the last slide, how do we know we're successful? Overall, if we are successful in addressing those social determinants of health, we will see educator attrition rates down, we'll see more people coming into our profession, and we'll see job and membership satisfaction up. And this is something that we monitor at OEA, and it is an area that we definitely are keen in working with as many people as possible in improving, so that we have an incredibly robust quality education system here in Oregon for our students and for our educators. That's all I've got. Thanks, everybody.
We should have an applause feature.
Yeah, thank you so much. Great. Sounds like JJ's back. JJ,
I have returned.
Jeff,
If we
you're
want to
on
go to,
mute.
I am not muted.
Jeff is mute.
I think I'm on. There we go. Oh, too far. Back one more. There we go. Ah. All right. So thank you, everyone. I will be quick. Social determinants of health is a bit of a buzzword. So I just wanted to define what I mean by that as it relates to county government. My presentation is more about what we do as a whole for the community, not just for our employees. So there's lots of things that lead to your health outcomes, not just your healthcare. And so the 4 areas that I'm going to address are economic instability. Ultimately, if there's issues with your financial well-being, that's going to lead to poor access to healthcare, poor nutrition, all kinds of different things. Housing crisis is a major issue. And in Southern Oregon, unfortunately, we had some major fires and lost a few thousand homes. So an already stressed system has been exacerbated. Transportation, a lot of folks, issues with getting to work, getting to healthcare, lead to poor health outcomes. And then lastly, public safety. Poor public safety leads to all kinds of issues related to increased stress and economic strife. And so these 4 issues I'm going to talk about what the county is doing to address them. Next slide, please. Thank you. So we'll start off with economic instability. A handful of programs we have are designed to help the economy locally, and local government only has a certain amount of influence over what's going on in the economy. But a handful of things we do. First off is we get money from the Oregon Lottery, and we use that money to fund grants and loans to both help small businesses start and also businesses to expand their operations. So we work with a number of agencies through our community colleges to vet those businesses and try to help them grow through that small investment for each one. We also have a handful of workforce development programs in our community. We have an internship program through our local high schools where they can work and get credit in their classes and then work in different departments to learn about the different fields. And then a few of our departments have paid internships. We have a program with our building safety department. There is a workforce shortage of building inspectors. So we created a workforce development program where we can train people to be building inspectors, bring them on as paid interns, get them up to speed, and then we can help address that workforce shortage. We've also done that with mechanics as well, because there's a general shortage within that demographic. And then lastly, we've done a lot of updates to our land use code to have more business-friendly land use regulation. So we allow businesses to do certain things in different areas, and we allow the process for getting variances if they don't quite meet the code to be more streamlined and easier to handle, so that the business can come in and quickly get up to speed in an effective manner. Next slide, please. Housing, again, that's a real challenging thing. We are a fairly rural county, and a lot of the houses that are in our area are not on city water. They have septic programs and wells. And one of the challenges if you're going to build a house in a rural area is the septic approval process is through a state-run program through DEQ, and it's pretty cumbersome, and it takes many weeks to get approval. So we worked with DEQ to take over that function both within Josephine and Curry County, and through our community development department, we hired a handful of inspectors, and we now run all of that program inside. And instead of it taking 1 to 2 to 3 months to get that approved, we can do it in a matter of a week or 2. So people who are trying to build houses can expedite the processes. Also a challenge with this housing issue is secondary dwelling units. A lot of rural properties have space to build secondary homes or the mother-in-law suite, so to speak. But a lot of the code makes it challenging to administer that. So we have changed some of our code to make it easier to administer that. Another challenge is the profit margin on multifamily dwelling units in Southern Oregon is much lower than it is in the metro area. So a lot of the people who have the money to invest in those properties are unwilling to do it down here. They'd much rather make a 20% profit instead of an 8% profit. So we work with the Federal Housing Administration and then county government to get some seed money to incentivize some investors to build some multifamily dwelling units here in Southern Oregon. Next slide, please. Transportation, again, if you don't have good transportation, getting to healthcare, getting to work can be very challenging. So we do have a transit system in Josephine County. And so we've secured a number of grants that have allowed us to both expand our routes and to expand our operations. So now we have a pretty pervasive reach to all areas of the county, both with a fixed route and then also site-to-site transportation. And with COVID, we've learned that sometimes it's not about getting to work, it's about getting online, going to school online, et cetera. And a lot of our rural areas have fairly poor access to broadband and internet. And so we've been working with a lot of the providers and regulators to expand rural broadband access. Next slide, please. All right, lastly, public safety. Josephine County for quite a while was famously underfunded in law enforcement. We used to receive most of our funding for law enforcement through timber revenue, and we used to get about $14 million a year in timber revenue. That has shrunk down to only about $2 million a year. And when I first got here, we only had 4 patrol deputies covering the entire county, which was terrifying. Since then, we have secured a number of grants, and we, went out to the community, built support, and they opted to fund a levy. And that has allowed us to go from 4 deputies up to 32, including a detective unit and a resident deputy unit. We also use that money to expand our juvenile justice department. So we were able to reopen the juvenile justice shelter and detention and filter kids who were likely to go into the criminal justice world and hopefully stop them, reduce recidivism, and get them to stay out of that realm. So those are all the various different things we're doing to help people in our community that ultimately those decisions will affect their general health. So that's all I have.
Thank you so much, JJ. Let's see, Sue, did you have?
One slide.
All right, perfect.
Brevity. And so, because I was banking on my colleagues to do the outstanding job that they did so that I wouldn't have to repeat it. So thank you to both Reed and to JJ. But I will speak to these points because I think what they've done a great job of doing is giving you an overall umbrella, and I can speak to specificities relative to how that might play out in a district. And I'm going to offer up Tigard-Tualatin School Districts as an example. So again, we had the same concerns relative to our health, safety, and both emotional health as well as physical health, because we know a healthy workforce stays focused to our primary mission, which is educating all children. And again, Reed has done an excellent job of explaining how teachers really are focused to that mission. So starting from the economics, we enjoy a very solid and robust relationship with our associations. We hold weekly meetings via labor relations and work through contract issues. We take that very seriously because we know that that is the first level in which we are going to hear about concerns that are impacting any one of these coming up from either our classified or from our licensed associations. And that also includes our administrators, which are in a confer and consult relationship with us. But we value those labor relation weekly meetings. And certainly it helps us frame how we're going to navigate contract negotiations. For us, we pay very close attention to the TriMet cost of living. Relative to our benefit packages, we have one of the richest packages of all districts in Washington County. Originally, before I came into the seat, there were 5 plans that were offered from OEBB. We now offer all plans because we believe the greater the choice, the greater the ability for families to tailor to their specific needs and concerns. We have found that to be of great benefit to our families. We also offer HRA Viva because we noted that in our classified staff, they, particularly the younger that they are, they're more concerned about cash in hand versus net benefits. As they age into our system, we see those shift. So to have, again, that wide breadth of choice and that sense of greater control over your benefit package has gone a long ways to sustaining our workforce in the Tiger-Tualatin School District. Housing is a huge concern in our district, simply because we have the pressures of the TriMet area. Over 10%, interestingly enough, of our workforce resides in Multnomah County. So one of the things that I and Washington County superintendents have been a large piece of is working with our local communities in terms of offering greater choice and availability of moderately priced home, either housing in terms of multi-family dwellings or single family units. And there is a tremendous amount of work that's being done both in my district, on the Tigard and on the Tualatin sides, in terms of securing federal grants to support that, knowing that we do not want to push our staff and our families out into the margins where housing is less expensive and drive times are longer for our staff. And we also have within the Washington County superintendents, we have individuals who actually represent us on the Metro. Myself and others are engaged with both our county commission, both in my case, I have a footprint both in Clackamas as well as Washington counties. And so actively involved with their county commissioners and with their county chairs, as well as West Side Economic Alliance, which is an economic alliance of individuals from as large as Intel and Nike, all the way down to small family businesses and storefronts. And so it provides us a seat at the table to share the needs of our community, of our staff, and the decisions that they are making as business owners. They were one of the first to embrace us when we had the conversation relative to the Student Success Act funds and how we wanted to tailor those dollars to address class size for our staff, as well as mental health services for our students. And they were most receptive as a business entity to learn about that and to ask really formative questions about the CAT tax as that was being navigated through the legislature. Relative to transportation, again, we do advocacy with Metro. Right now, we are navigating light rail planning that is coming through the west side by Bridgeport shopping area mall. And that's caused a fair amount of consternation. In one plan, they actually had the light rail running through one of our bus barns. And so we had to have a conversation about perhaps reevaluating those maps. And but again, have always had a seat at the table where we can advocate for staff and staff transportation needs. Then relative to public safety, myself and my Director of Community Relations have monthly meetings with our city managers. We serve 4 municipalities: Tigard, Tualatin, Durham, and King City. We have active ongoing relationships with those city councils and with the mayors, and frequently have them to the table when we have issues that are impacting our staff and our students to help us make good decisions for the entire community. One of the things that I wish to give a shout out specifically relative to the needs of our staff to the Washington County Commission is the allocation of $1.1 million to Tiger-Tualatin and similar amounts out into the area districts to support childcare during this pandemic so that teachers can teach and know that their children have access to quality daycare. And we navigated as one of the benefits for teachers with our board, writing into their contracts that this was a part of a benefit package. Ourselves, Beaverton and Hillsborough followed suit so that we could keep our teachers and staff out of harm's way with the Oregon Ethics Commission, and just rolled it up as part of a benefits package. And that has been well used and will be extended to the end of this year. Additionally, Tiger Tualatin is very much mindful of the work relative to diversification of staff and has developed a staff affinity group of color to align with the affinity groups that we have developed for our families. And so because we know that is important to building that sense of belonging and having a place to share concerns and ways in which they are experiencing the workforce, so that we can retain them over the long period of time and sustain the work that we are doing. Additionally, the community has been extremely supportive of our teachers in the sense of continuing to recertify our local option, which brings in over $9 million every year in additional property tax. That allows us to keep our class sizes at one of the lower levels for a district our size. And we continue to appreciate the support that we have from our community. I think the last point that I would bring is the recent work relative to teacher vaccination and staff vaccination. And I certainly want to give a shout out to our fellow board member, Bob Stewart, for his heavy lifting that he did in bringing TriMet superintendents to the table with our healthcare partners. And then each of our boards in line certified and supported the concept that teachers and classified staff should be vaccinated prior to being in front of children and families. And we are in the midst of that. But I think, again, it speaks to the collective community response to how much teachers and classified staff are valued and are willing to put a personal stake in the ground with many members of our community that don't understand that and are not supportive and simply want their child back in the classroom, and have been willing to stand tall with myself and with our staff in letting individuals know, our community know, that this is an important piece in terms of keeping everyone safe so that we can educate our children at the highest levels possible. So with that, that would be the end of my presentation.
Thank you so much, Sue. That was a great deal of information. Really appreciate you taking the time to put that together. Tom?
I'm going to suggest that I do my 10 to 10-minute discussion next board meeting because of, one, the time, and two, my focus is going to be more on health equity and health disparities and weave in some of the things that we just talked about. But I think it's, I mean, I could do it now, but we also have still a lot of things to go over.
Okay. Sorry, I was on mute there. All right, thanks, Tom. Let's move to our reports from work groups. I guess I'm next with the Innovation Work Group update, and I can do this in fairly short order. As this is the process, our agenda for the last meeting was to have an update on legislation. We spent most of our time looking at the results of the Centers of Excellence RFI and discussing how PEB and OEB could jointly be pursuing higher quality of care through a Centers of Excellence approach. That discussion largely ended on starting with specifying standards that we would like our current carriers to aspire to, and identifying those facilities that could provide that. That's where we will be picking up again next time. We also had a report from the OHA on the healthcare cost growth target program and updates on that. And we also had some further discussion on when and how we would approach the Lodestar program that we've had a presentation on before. So I'll keep it at that unless anybody has any questions. Okay, move this on to Tom for the CIO update.
CIO spent 2 hours and 15 minutes talking today and getting very informative reports. So trying to distill it into just a couple minutes is a bit of a challenge. We had the annual pharmacy report, and the highlights are that both MODA and Kaiser Permanente are beating best in class in terms of price of cost over the past 3-year period of time. When we look at KP's numbers, basically have been flat now for the last 3 years. MODAs have been increasing. When you average the 3 years of plan 17-18 through 19-20, averages probably about 4%, which is hugely better than what's happening in the community. Pressures for increases, if you watch television, we're saturated by ever increasingly costly but effective treatments that have risks and all of that. But giving that the point, the idea here is that we've got well-managed programs that, and yet we need them to continue to be well-managed and continue to look for better approaches in the future. Probably the biggest one that's coming is MODA's effort around chemotherapy. If you remember last year, we ended up putting a site of care requirement for some of the supportive treatments, and we're going to be exploring for actual chemotherapy in a way that makes people, in a way will enhance options and get care hopefully closer to people's homes. The next topic that we discussed was transgendered benefits, and was actually quite reassuring in that when we look at what the recommendations are by the World Professional Association of Transgender Health, both Kaiser Permanente and MODA are providing significant benefits to help people who are needing medical support. The one area that where there was a gap between what Kaiser's performing and what MODA's covering has to do with its gender conforming facial surgery. And there's you saw in the rate discussion, a 0.2% rate impact by adding that. Kaiser Permanente already has that in place, and MODA does not. But the types of things that already are include mental health coverage, hormonal therapy, breast and chest surgery, and genital surgery. So really, again, from my viewpoint, when we look at health equity, we are doing a wonderful job, and there is some improvement that we can get to. We looked at the wellness programs that OEBB offers. The first thing we talked about was Canary Health's chronic disease management program and their diabetes program. Their utilization hasn't been, for the chronic disease management, isn't high. The diabetes program that they offer is good. Both MODA and Kaiser offer similar programs, and yet there's still utilization that's outside of those two health plans. We are paying for that on a per participant basis, which it's basically what we're doing is we're increasing options. We're going to continue to focus and see what happens as MODA has expanded their disease diabetes program with the Livongo platform that they just brought on. So that'll be something we watch over time. There's the Healthy Team, Healthy You, which is now on its third iteration in terms of corporate owners. Staywell was bought by WebMD, and we're looking at, this is a fitness, health maintenance, stress management online platform that people can participate in. We've had participation that's significantly higher 3 or 4 years ago. It's dropped, whether or not it's because of the pandemic or that they stopped giving out monitors and blood pressure cuffs. We don't know that. And they've proposed a per employee per year payment structure. We've asked our consultants and OEB staff to go back and see if we can get that back to a participant level. And then finally, Weight Watchers, WW and Curbo, those numbers have been sustained throughout the this past year, and their prices are set, and so we're pretty happy there. The last topic had to do with the benefit and program recommendations from MODA. You ended up hearing briefly those. There's the chronic disease management, musculoskeletal, advanced imaging, and medical dental integration programs. We'll be looking at them next month, and with the idea of being able to give recommendations from the evidence basis for these potential changes to the board as we continue through the rate setting process for next year. And that's the quick summary. Any other comments from other CL members?
No, great summary.
That's it, Jeff.
I'm sorry, I keep muting. Thank you, Tom. So Glenn, what do we need to know on the legislative front?
Oh, there's always lots to know, Jeff, but I'll try. I don't give you a 5 to 10 minute upgrade on it. Well, first of all, just for those folks, you all know the session started on January 19th. It's going to run through June 27th. They have started committee hearings, but mainly informational. They have also scheduled presentations. I believe Tab and OEB are, isn't it the first week of February that they're going to be going in?
Yeah, Jeff and I and Kimberly from PEB are up Thursday. So
okay,
a couple days.
So yeah, just also folks, it's going to be a mixture of remote and on-site hearings and meetings. They haven't totally, but this also means that because they're doing the remote, they don't have as much time. So there's a lot more upfront desire to identify potential fiscal impacts versus in the past where it usually kind of wound its way through the system. The first marker really will be mid-March when you have to get a bill through your policy committee, both having a public hearing and a work session with a vote. If they don't have it by then, unless the bills move to are in the Ways and Means Committee or the Revenue / I also will say, then it's dead. But let's go into the legislation. We divide the legislation, and HBA actually in itself does this too, really into 5 different categories. I'm just going to go over the priority 1 bills. Priority 1 would be ones that have a direct impact on OEB, either through policies, programs, some on costs, but it's usually more, they're really just going to change their programs. The first one is a bill that we saw last year. It's a bill that's going to change our HB 2557 program to where instead of it being self-pay, they're going to divide the cost sharing between 10% for the individual and 90% would come through a general fund appropriation to OEB. It's very costly in regards to the premium support that the state's going to have to pay, but it also has impacts from the sense of we'd have to change our system, get more personnel, and it will have a premium impact. But last time it was around 0.2, 0.3, but Willis Towers Watson is reassessing that. The next one is that I don't know what's called pharmacy tourism. There are programs where people are usually through their employer, and also one state we know of, Utah, does it, where they actually pay people and they work with in specific usually specific pharmacies, hospitals in Canada or Mexico, to have them fill the prescriptions, usually the top specialty medications in Mexico or Canada to try and reduce costs. We're doing bill analysis for it right now. We had a meeting with Utah. They've only had 16 people participate. And it's roughly, if you use that percentage of participation for ours, including using the same list of drugs they did.
Okay. Well, Ollie, anything else that you need to add to this?
No, we can send the rest of the bill list out to the board. I just want to thank the board members for their social determinants of health presentations. And we're putting together a joint committee of 2 EB board members and 2 OEB board members. I'm got my list to talk to Sue and Tom about that. Just make sure that we're moving our health equity work forward. And I know the boards have a lot on their plate right now. So otherwise, no, that's it. Thank you for joining us.
Well, as an add-on to Glenn's thing, I wanted to mention that the Speaker's office reached out to me to discuss pending legislation that would impact OEB. So I'm grateful that they are, looking for perspective or input. So I'll be able to report on that next time. And I have to ask the question, any public comment?
No public comment.
Well, we're not too far over 8 minutes. Thank you all very much for your attention. We are in the thick of it. And remember, we may not use it, but there is a second board meeting scheduled in April in case we need it. So please keep that on your calendar until further notice. Be well, and we will talk to you later. Thank you.
Thank you, Jeff.
Meeting adjourned.
Thank you. Bye, everyone. Thank you.